It's my honor to be here to present the subject of the prevention of heart failure in patients treated for cancer. Why are we focused on the cardio-oncology? Recent years, the prevalence and the death rate of cancer have been decreased with progress of medical technology. However, cardiovascular disease became the second leading cause of the adverse outcome in cancer survivals with improvement of cancer survival rate. Cancer therapy have developed from the traditional chemical therapy to target therapy and immune therapy. The overarching goal of the cardio-oncology discipline is to allow patients with cancer to receive the best possible cancer treatment safely, minimizing cancer therapy-related cardiovascular toxicity across the entire continuum of cancer care. The key cardiotoxicity is focused on the cardio dysfunction, myocarditis, vascular toxicity, hypertension, and arrhythmia such as QT prolongation and atrial fibrillation. In 2022, ESC published the first guideline on cardio-oncology. This guideline provides guidance on the definition, diagnosis, treatment, and prevention of the cancer therapy-related cardiovascular toxicity, CRT-CVT, and the management of the cardiovascular disease caused directly or indirectly by cancer. This guideline provides a personalized approach to care based upon the baseline cardiovascular toxicity risk assessment and new protocols for cardiovascular surveillance during cancer treatment. Decision-making depends upon the risk-benefit balance of oncology treatment efficiency and the severity and impact of CRT-CVT. Risk stratification and monitoring is important to detect early cardiovascular toxicity. Guidelines emphasize that baseline cardiovascular risk assessment is recommended for all patients with cancer scheduled to receive or potentially cardiotoxicity and anti-cancer therapy. Yes, guidelines provide a detailed step to risk assessment. Half-across risk assessment tools should be considered to determine pre-treatment risk of CTR-CVT as they are easy to use. Cardiovascular prevention strategies require a personalized approach. The optimal time to consider cardiac prevention strategies is in patients with cancer is at the time of the cancer diagnosis and prior to starting cancer therapy. A baseline cardiovascular risk assessment is recommended for all patients with cancer scheduled to receive a potentially cardiotoxicity anti-cancer therapy. A risk stratification is an important step prior to starting cardiovascular protection. Patients with different cardiotoxicity risks are supposed to receive different cardiovascular prevention strategies. CRT-CVT risk is a dynamic variable, and the risk changes throughout the pathway of care. The absolute risk depends on their basic risk and change with exposure to cardiotoxic therapy over time. Primary and secondary prevention strategies play important roles in decreasing risk of cardiotoxicity after initiation to cancer therapy. Prevention and management of the CTR-CD. Guidelines provide us with a symptomatic definition of heart failure. It also categorized heart failure into asymptomatic and asymptomatic cancer therapy-related cancer dysfunction, CTR-CD. The main criteria was based on the left ventricle ejection fraction and the severity of the patient's heart failure symptom presentation. Measurement of cardiac biomarker, cardiotropiny, I and T, and BNP and NT-proBNP help in baseline cardiovascular risk stratification of patient scheduled for cancer therapy. Echocardiography play important role in cardiotoxicity evaluation. A number of observation studies show potential for reduction in GLS to accurately predict a future decrease in LVEF and significant cardiotoxicity. Multimodality imaging play important role in prediction subsequent cardiotoxicity after receiving cancer therapy. Echocardiography is the first-line imaging modality to assess cardiac function in patients with cancer before, during, and after cardiotoxicity treatment. CMR can provide a current assessment of myocardial structure and left ventricle function. Multimodality imaging can provide complementary information that may be helpful in evaluation of select patients with cancer. 2022 ESC cardio-oncology guideline have offered some recommendation about CTRCD prevention, including the timing of starting prevention, using dextrosozin and change to liposomal anthracyclines. Besides, subjects for cardiovascular disease play an important role in CTRCD prevention, such as RAS inhibitor, beta block, and statins. Primary prevention of cardiovascular toxicity from cancer therapy aim to avoid or minimize the development of CRT-CVT in patients without cardiovascular disease. Secondary prevention refers to intervention in patients with pre-existing cardiovascular disease, including prior to new CRT-CVT. MDT is recommended when patients with cancer have complex cardiovascular disease that may impact on their cancer treatment. ESC cardio-oncology guidelines have summarized detailed management strategies for cardiotoxicity patients receiving cancer therapy. The use of an ACR, ARB, or RNA beta blocker, SGLT2, and MRI is recommended unless the drug are contraindicated or not tolerated. Guideline-based heart failure treatment is recommended in patients who develop symptomatic CTRCD or asymptomatic moderate or severe CTRCD during anthracycline chemical therapy. Different chemical therapy has its own management strategy. Temporary interruption of anthracycline chemical therapy is recommended in patients who develop symptomatic moderate CRCD, and a multidisciplinary approach regarding the decision to restart is recommended, is class 1 recommendation. Temporary interruption of HER2 target therapy and initiation of heart failure therapy is recommended in patients who develop a symptomatic severe CTRCVD. The recent ACC 2024 published a clinical trial about the effect of ACI in cardiac damage protection from chemical therapy. However, study found no difference in troponin biomarkers up to 1 month after anthracycline treatment. Therefore, focus on the RNA anti-SGLT2 in cardiac protection for CTRCD is important to improve the clinical prognosis in patients with cancer. A retrospective multi-center registry study in 6 Spanish hospitals, including 67 CTRCD patients, exploring the potential benefit of RNA in patients with CTRCD. RNA improved the echocardiography function and structure and parameters, NT-proBNP level, and symptomatic standards in patients with CTRCD. The upcoming AHA 2024 will publish the clinical trial results from the protective effect of RNA in CTRCD. We expect the result in this clinical trial and the application of RNA in CTRCD protection. SGLT2 inhibitors were associated with the low rate of cardiac event, however, the higher survival among patients with cancer and diabetes who were treated with anthracyclines. A recent study evaluated the effect of the cardiac protection of SGLT2 inhibitor in CTRCD, and the results reveal that patients with SGLT2 inhibitor experience low risk of acute heart failure exacerbation, all-cause mortality, all-cause hospitalization, atrial fibrillation, and kidney injury. SGLT2 inhibitor has also cardiorenal protection in patients with CTRCD. Previous research have explored cardioprotective application of statins in patients' diagnosis with cancer with receiving anti-cancer therapy. ACC 2026 propaged the result of study in prevention the cardiotoxicity from anthracycline. The study showed that prophylactic use of statin in patients with receiving anthracycline for 12 months were associated with low risk of cardiac dysfunction. The risk of meeting adverse endpoint in patients receiving prophylactic statin was lower than those receiving placebo. In addition to medication, exercise can enhance cardiorespiratory fitness and reduce the risk of cardiovascular disease in patients with oncology heart disease. This reveals that it's not only the use of medication, but also the improved patient's lifestyle that should be monitored by the healthcare professionals. A multidisciplinary cardio-oncology team. So cardio-oncology treatment design process is balanced risk of cardiotoxicity and benefit of cancer therapy. We established cardio-oncology clinic multidisciplinary team in August 2016. We established the standard process of CTR-CVT evaluation based on guidelines and provide cardio-oncology consultation for cancer patients. So the HARF-ECHO score allows us to conduct a current CTR-CVT baseline risk assessment, but risk factor varies according to the anti-cancer drugs. It is difficult to apply widely. Surveillance protocol varies according to the cancer treatment region. So in this area of big data and AI, in order to overcome difficulty in the implementation of the guideline, we originated the COGPT software for cardio-oncology screening and evaluation. Through this software, we can achieve AI evaluation based on clinical data, alert clinicians for risk stratification regarding current monitoring and follow-up. So our oncology work is published in European Journal. So include cardio-oncology is the integration of clinical disciplines. Cardio-oncology prerequisites must have knowledge of the broad scope of cardio-oncology, oncology, and hematology management. The management of cancer patient is characterized with heterogeneity. A risk stratification is an important step prior to starting cardiovascular protection. Patients with the different CTR severity risk stratification and different cancer treatment strategies received different CTR severity monitoring protocol and cardiovascular protective therapies. Up to now, more and more cardio-oncology clinic centers set up. More than 30 cardio-oncology societies have established. We are devoting to improve outcome of patients in China. So together we co-cure. Thank you very much.